Welcome to the CRST Journal Club. I'm Dr. Terry Kim from Duke Eye Center, and I want to thank Dr. Gary Foster for joining us today. Dr. Foster is a good friend and colleague of mine, and he's a prominent cataract refractive surgeon in Fort Collins, Colorado, so thanks for joining us today.
Yeah, glad to be here.
Yeah. Well, Gary, you're a very, not only prominent, but very forward-thinking cataract and refractive surgeon. Every time I sit with you in some type of meeting, you've got the latest and greatest gadget. And most recently, I hear you've been using the Centurion unit for your phaco procedures. Maybe share with us what that's meant to you. Has it been a big advance? Did you expect it to be so? And what does that technology offer?
You know, I've been really pleased with it. This is a hard time in this environment right now to be investing in equipment when your old equipment is still working exceptionally well. Mm-hmm. And so our group, I'm part of a large group, 9 ophthalmologists, 4 optometrists. And so these decisions aren't made by one person, and we all bring a different philosophy to the table on how we want to view advancements in technology. So everything that we do represents a group effort, and I think my partners are all great surgeons and progressive, but each have a different approach to that. So as we look at these decisions, it's very much, I think we represent a big spectrum of what you would see among different ophthalmologists in the United States. So if a piece of technology makes it through my group, it's been vetted very well, and it means that it's making something better for patients. It's helpful if it's something that's going to help pay for itself. When you're looking at a new piece of cataract surgery equipment to replace something that's working well, you aren't really looking at it being a financial benefit to you. It really comes down to, is it going to be better for patients? And as we've looked at it, and in my own hands and practice since we've been using it, the Centurion really does that. I feel like it's safer, I feel like it's more efficient, and I feel like I have the ability to get better outcomes with it, especially when I combine it with the Varion, which is moving through the pathway now.
So what is your advice to that cataract surgeon who maybe has an older either Infinity or Prestige or Stellaris or unit? Is there enough there to really motivate or prompt or justify jumping up to this next level technology with regards to phaco machine?
I think, for example, within my group, a number of my partners had hoped that this technology wouldn't be exciting enough that we would be moving up to it, but then we all tried it. And then as we get together to a man, each of us felt like it definitely advanced our ability to take good care of people, and felt like the expenditures involved, even though they're noticeable, paled compared to doing what we went into this business to do. And I think if you try it and use your current technique, but yet start to sense the advantages around the fluidics and the advantages around the AccuCert, and the decreased fluid going through the eye and the stability of the chamber, it allows you to operate in a much more efficient mode using more aggressive parameters, but sensing a greater safety net because of the regulated infusion.
So can you just talk briefly and maybe help us understand what are the actual differences? Are there some differences in terms of the fluidics? Are there differences? I've heard about gravity versus you know, gas or forced infusion. Could you maybe comment on what that's all about?
Absolutely. At the core, one of the big advantages of the Centurion is the regulated infusion. We become very used to and rely heavily on our control and ability to have the aspiration pumps work in a way that, and for them to vent appropriately. So all of the platforms have achieved a very high degree of efficiency in the way we're aspirating. But to this point, we've accepted gravity as what delivers our infusion. And if you want a little bit more, you raise the bottle, and a little less, you lower it, and you put up with a certain amount of pressure in the eye to achieve that. With the Centurion, for the first time, you have a BSS bag that's put down into a compartment, and it's compressed by plates based on the pressure readings that are sensed at the machine level. So as the infusion pressure, pressure in the eye, pressure leaving the eye, as those parameters vary, the plates either constrict to force more fluid in to keep a steady pressure in the eye, or back off a little bit to maintain that. So there's a homeostasis around the pressure in the eye not the amount of fluid that's being delivered. And so you regulate now not just the aspiration pump speed, but now the irrigation going in, and it's a much more stable chamber. So once you start to recognize you can count on that, that allows you to work at a little bit higher vacuum levels and to work a little bit more aggressively in the eye, but again, as I said, sense that safety net. And it's a big difference, and you can sense it right away. And fairly quickly you can start to move up into a more efficient way of removing the cataract because you can count on that chamber stability. As long as you don't end up with a very tight wound or kink your wound or something in some way where you decrease the amount of fluid going in, you can count on it to sense and deliver what you need. Real-time, very, very fast adjustments, much faster than a bottle could go up and down.
Right. Now, you also mentioned patient eye level, and this machine allows you to adjust for that, which I think previous technology hasn't been able to. Is that an important factor? How realistically relevant is that clinically?
I think the advantage on that is if you traditionally have your machine in one spot and use your OR table at a certain level and you can measure that patient eye level difference, then you can build that into the machine as a pre-programmed parameter that you're going to set, and it's easy to change on the fly. If you touch the screen, if for some reason you need to operate on somebody with unique positioning and you need to raise or lower that. But all along, what's been delivered to the eye in a gravity-based is the difference in height between the bottle height and where the patient eye level was. So this just allows you to program that in.
And what is your advice? I mean, this whole concept of now changing, instead of having your bottle set at 100 centimeters of mercury, now it's shifting towards this IOP parameter that you set. Is that something that's going to be pretty intuitive to the cataract surgeon? And what are your specific settings regarding that, whether it's a straightforward case or maybe a more difficult or complex case?
The first thing that's an adjustment for doctors is to recognize that there is a conversion factor, and they can find out what pressure they've been attempting to operate at. So if you have a bottle height of 105 or 110 or 115, wherever you've had that set, that equates to a pressure somewhere in the between 60 to 85, depending on where you've had that set. The problem is it varied throughout the course of your case. There were times you were getting all of that and times you dipped significantly down below that. By deciding the pressure where you're going to work the best, and what you need for that pressure will somewhat be determined by how aggressive you are inside the eye. People that do a slower, more gentle approach to lens removal will be able to run a lower pressure and put less fluid through the eye. People that prefer to minimize the microscope toxicity and the light and want to work in an efficient way and be out of the eye as soon as they can are going to set the pressure a little higher because they're going to be moving more fluid through the eye.
What's your standard setting?
Right now I'm using 75.
75
as the pressure.
Okay.
And to be honest, I'm in a mode of experimentation right now. I've been down at 60 some weeks, and that just happens to be what I did the last week I operated, and I'm trying to find what's the right comfort zone and what's best for patients.
Gotcha. And you also mentioned the AutoCert injector. Can you just tell us a little bit about your experience? I've heard anecdotally from surgeons, and I'll tell you, I'm in that camp too, where I saw this. I didn't really feel like it was going to be something I would adopt really on a regular basis. But as you alluded to earlier in your comments, once you use it, in your example case, the Centurion, I found that the case with the AutoCert, you'll become a believer of it. Is that what you found as well?
You know, I had seen that at some of the meetings before as they had demoed that or talked about this, and there seemed to be more excitement from the engineers than what I felt as a surgeon looking at that. But once I started using it, I recognized it really is a big step forward. And my history of getting there was I had been a twist Monarch style injector, and then there was a big craze some years ago where we all started using injector style, whether it was plunger regulating or piston relating, preventing an over-injection. But the first time you get an over-injection, what I found is that I really liked the control of that because I didn't have to push as hard, which felt more comfortable to patients, didn't have to rotate the eye out of my view, and so there was a big preference on that for me until you had a safety issue with it. And so then I left that, as I think most of my colleagues did, and went back to a twist style injection system. The beauty of the AutoSurt is I get the control, I get the decreased pain because I don't have to push as hard for the patient when I'm injecting. I never lose sight of the IOL as it goes in.
Right.
Major advances, all of them, but the big thing is I don't have to worry about an over injection damaging the eye.
Right.
So I pick up all of the plus, none of the negative. It was an advance that vastly exceeded what I predicted it would.
So Gary, you mentioned the Varian and how that's part of, you know, the cataract refractive suite. What is Varian and how is that going to change what we're currently doing now with cataract surgery?
So Varian allows us to remove many of the human errors that currently can be introduced into our system. So the beauty of that is you will enter patient data one time and that patient data will transfer through the system. That removes many elements of human error. Second, it integrates with the technologies so that at the reference unit with the Varian, it determines the Ks, and it also takes a high definition photograph of the eye, and those two are married together. That allows you throughout the process to reference that and to line up your astigmatism work, your incisions, and that transfers through the case. That removes many elements of human error. Allows you to do planning right on the Varian reference unit itself so that you can choose the IOL, you can decide the length of the arcuates, and there's a built-in nomogram for that. You can decide how much is fixed by the toric versus the arcuates, and again that plan moves forward. Then as you hit the lens X, it allows you to center based on those photographs taken earlier, either centering on visual axis, centering on undilated pupil, or on the limbus, so that you have a more centered rexus, and then it transfers forward to the Varian, and you can control these screen overlays with the foot pedal, which is wireless on the Centurion. You can then have it project forward to you where your plan was to put the incisions. That removes some human error. It's in the right spot. And then when it comes time to put in your multiple focus lens, it'll help you center that based on either the visual axis or the undilated pupil. And then afterwards, data flows back into that. All of the Centurion data flows forward with that data set. So then as you put your outcomes in later, it goes back to the reference unit and can help you determine surgeon constants. It can help you decide based on outcomes, based on settings on the Centurion, what is your most efficient way to help people, where are you getting your best outcomes. And so it's a continuous loop that removes human error on many levels and improves outcomes.
Well, thank you very much for sharing your insights. We could go all day with all the stuff that you're using in terms of your advanced cataract and refractive procedures. So I want to thank you for joining us today. Again, Terry Kim from Duke, signing off from CRST Journal Club. Look forward to seeing you at our next session.